This will be the syllabus of my presentation. Firstly, my pronouns to Professor G.S. Eisenbach. For those of you who have followed the literature, late Eisenbach's name is synonymous with type 1 diabetes in the world literature. He happened to be my supervisor during my tenure in the 80s at the Duke, Joslin and Harvard. This is the famous model of type 1 pathogenesis which you will find in every textbook of medicine and diabetology world over. Regarding the pathogenesis of type 1 diabetes, in the mid-80s, we summarized the situation based on our own work and work from across the globe. That autoimmunity directed against the pancreatic islet cells results in slowly progressive beta cell destruction, culminating over years in clinically manifested insulin-dependent diabetes. Circulating serum antibodies directed against the endocrine cells of the islets, the beta cells, are an important hallmark of this disease. That assays for islet cell antibodies have facilitated investigation and understanding several facets of the pathogenesis of autoimmune diabetes. Their application have begun to extend into clinical practice and have opened new avenues for early preclinical prediction and preventive prophylaxis in IDDM. These words continue to be true even today, though a lot of hope remains. As many of you may know, before the 80s, type 1 diabetes was considered an acute disease with hyperglycemia and ketoacidosis. But this changed with the discovery of what we refer to as pre-type 1 diabetes, that refers to the preclinical asymptomatic autoimmune beta cell destruction spread over even a decade. This came as a work done at our center in Joslin and all over the world. This is the current model, and according to which, after birth with genetic predisposition, there is initiation or triggering by as yet unclear environmental factors of an islet cell autoimmune selective response, which gives rise to progressive beta cell destruction, and finally when almost 90-95% of beta cells are destroyed, you get type 1 diabetes. Based on this work, we set up the world's first pre-type 1 diabetes registry in the 80s at the Joslin. The dream at that time was antigen-specific immunotherapy, and hopefully one day to prevent. It remains a dream today. These are the same stages. I'll touch upon it later. A few words about genetics. Most of you know that the major genetic susceptibility resides in the MHC class 3 on chromosome 6 and the DR3 and DR4. Right now there are more than 40 susceptibility genes for type 1 diabetes besides the HLA and the insulin. The initial genes were identified by the candidate gene approach and the subsequent by the GWAS approach. This summarizes the various mechanism of action possible of the T1 susceptibility genes. As you know, many of them act at the level of the autoimmune mechanisms, some on protection from beta cell apoptosis, and one possibly on insulin production and metabolism. The DR3-4 confer high risk, where DR2 is protective. I will touch about these topics later. In the mid-70s, the pathology of insulitis was described, and these are the various stages of insulitis: pre-insulitis, peri-insulitis, intra-islet insulitis, complete islet destruction. This from the animal model. Recently, very interestingly, differences in the insulin content between the islets have been shown in T1, some having lot of islet cells, some totally destroyed, meaning it may not be a single hit, multiple hit with destruction and regeneration going in parallel. Another interesting phenomena is known as lobular destruction. In the same patient, in one lobule, all the islets may have beta cells. In the neighboring lobule, there may be no beta cells, suggesting a patchy pathobiology like, say, vitiligo or autoimmune thyroiditis, suggesting that the beta cell destruction need not always be complete, need not always be inexorable, and we may have a window to interrupt the same. One of the landmarks in this field was in 1974 when Dr. Pathogenesis discovered the islet cell antibodies cytoplasmic in England. I'm glad to let you know this was my postgraduate thesis. We are perhaps the fourth or the fifth in the world to develop independently in Delhi much before the Americans. Besides the classical islet cell antibody assay, there are several autoantibodies directed at biochemically defined islet cell antigens. These include insulin, glutamic acid decarboxylase, tyrosine phosphatase-like protein, and zinc transporter. This is the myriad of potential islet cell antigens identified and their subcellular location in different parts of the islet. If you take a large number of newly diagnosed type 1 diabetes children, the prevalence of the various autoantibodies varies from 92 to 44%. In the same series, more than 98% of the children have more than one or more antibodies, and 80% have about 3 or more antibodies. The behavior of the various antibodies is slightly different. At the earlier the diagnosis, higher the prevalence, and decreases with age of diagnosis, except for glutamic acid decarboxylase. A special word about insulin autoantibodies. They are highest in younger children, and they predict faster rates of beta cell destruction. Once the beta cells are destroyed, the antibodies disappear at varying rates. MHC haplotype sharing, DR34, increases the risk both for autoantibody positivity as well as progression to diabetes, shown in the red line. On the other hand, even though you have antibody, you're antibody positive, if you have the 0602 haplotype, you're protected from development of diabetes. A few words about environment. Of all the factors, the one definite factor is congenital rubella. About 3 to 20% of these children develop insulin-dependent diabetes when they grow up. The other predisposing factors include enterovirus, rotavirus, dietary components like gluten and cow's milk. The protective factors could include gut flora, helminths, viral infection, and vitamin D. Following the establishment of the Joslin Pre-Diabetes Registry, all over the world, several natural history studies have been established, like the Diabetes and Autoimmunity Study in the DAISY, DPT-1, the Environmental Determinants of Diabetes in the Young Teddy, Prospective Assessment in Newborns for Diabetes Autoimmunity, PANDA, the DIP, etc. Example, one of the studies. These studies either have to study a general population where nobody has diabetes, or families where a sibling or a parent have type 1 diabetes. You have to enroll them. It's a stupendous task. For example, you have to enroll them right at birth and study them every 3 months a year for as long. Collect the interviews for the diet, etc. Collect blood samples, DNA on a long-term basis. This is one of the natural history studies which shows to you that autoantibodies start appearing as early as 3 months after birth. Another interesting finding was that in the group of babies where cow milk formula was introduced earlier than 3 months, there is high titer of antibodies to bovine insulin compared to the group which was exclusively breastfed for more than 3 months. If you take the relative risk of developing type 1 diabetes, in infants who are exposed to cow's milk before 4 months, it is 1.6. Whereas those where breastfeeding was less than 3 months, it was 1.5, meaning about 50% more. Based on this, one of the studies called the Trigger asked the following question: is it possible to reduce the frequency of disease-associated islet cell autoantibodies and clinical diabetes by the age of 6 years and the cumulative incidence by 10 years, provided we wean these babies to a highly hydrolyzed formula called casein hydrolysate instead of cow milk formula over the first 6 months of life. I will show you the initial data in the end. Several studies have shown that vitamin D supplements may be protective. Vitamin D supplementation lowers the risk, whereas suspected rickets increase the risk for type 1 diabetes. Few words about prevention. Same natural history graph. The prevention trials can be primary prevention at the genetically risk before they have developed autoantibodies, whereas secondary prevention trials are after the infant has developed autoantibodies. Finally, the intervention trials are when the child comes with ketoacidosis, new diagnosis, where almost 95% of the cells are dead and gone. An example of primary prevention. In the trigger study I mentioned, casein hydrolysate formula delayed the initiation of beta cell autoimmunity, and it has also retarded the development of type 1 diabetes. Results will be out 2 years from now. Examples of secondary prevention. If you have a child who has antibody positives, in next 20 years, 100% of them will develop type 1 diabetes. Can we do something to reduce it or postpone it? Several trials. In the DPT trial, parental insulin did not delay the development of T1D. Oral insulin also did not delay the development in this study. However, very interesting phenomenon, if you identify children with high titers of insulin antibodies, if you give oral insulin, in these children, T1DM was postponed by up to 10 years. Now, interventions. Once the child has developed diabetes, you can target autoimmunity, beta cell regeneration, or protect the beta cell mass. A large number of drugs have been used with limited success: mycophenolate, heat shock protein, exenatide, anti-CD3, GAD, proinsulin, gastrin, etc. But still there is a lesson which we can implement. In the 80s, cyclosporin did increase the remission rate in new onset diabetes. It did not last, and there was nephrotoxicity, so it was abandoned. Several anti-CD3 antibodies do preserve beta cell function even if you administer at a late stage. The question is how to adapt it for the pre-diabetes. Several other antibodies. Now, combination therapies are being explored. Again, lot of cocktails. I don't know where it will end. Cord blood therapies are being explored. The bottom line is to restore the balance between immune regulation and autoimmunity. Now, this is the battlefield of the beta cell islet, from the B lymphocyte, T lymphocyte to beta cell, with multiple potential targets for intervention. Now, let me conclude by taking you through a small flashback between the two mentors. This is Professor Ahuja, the father of Indian endocrinology, my mentor in Delhi, and this is Professor Soldner, world's foremost islet cell clinical physiologist based in the Jocelyn. The story is the 80s. Before initiating the 80s, we demonstrated that the children in India have the same characteristic, autoimmunity in genetic as in the West. This got published in New England Journal of Medicine, and accidentally this won me a fellowship at the Jocelyn. In the Jocelyn, I met Soldner on the first day. For the last 30 years before that, this scientist has been painstakingly studying twins and triplets who are discordant for diabetes. The child gets diabetes, he would study the non-diabetic twin and triplet. He would call them every 3 months, challenge their beta cells with oral insulin, IV arginine, IV glucagon, tolbutamide. Dr. Soldner was dreaming for a metabolic marker to predict pre-type 1 diabetes. On a breakfast meeting, I requested him, I have this made in India assay from Delhi. Will you give me all your stored serum samples? And within 2 days, he gave me 2,000 samples. And next 2 weeks, we ran the assay. And this is the remarkable result which changed the face of this disease. This is an antibody negative triplet who had persistent insulin secretion and never developed diabetes. On the other hand, his triplet mate developed antibodies, and along with it there was a slowly progressive decline in beta cell function, there is destruction, and 8 years later this twin developed diabetes. In fact, the data in this circle is the basis of the model of type 1 diabetes which I mentioned earlier. This is the world's first seroconverter. Here is a twin which was islet cell antibody negative, becomes positive in 75, high titer insulin antibodies, and destroys and develops diabetes 8 years later. The Harvard glorified this discovery. And this was the team. There is one more small discovery made at this time, which many of people do not know. Dr. David Sutherland is the world #1 pancreas transplant guy. He called me one day that when he did twin-to-twin pancreas transplant, after 30 years, the graft would lose. So when we analyzed the samples, what we found was, the moment the body sees fresh beta cells, it mounts a severe autoimmune response, not over years but within months, and destroys it in few months. We gave this the name recurrent autoimmune insulitis. It means that destructive autoimmune memory is anamnestic, never forgetting, and unless we can erase it, this disease cannot be cured. All of you know that zero was discovered in India and computer science flourished in the US. So probably history should call the model as the Solner-Ahuja model for the painstaking work. At the same time, in the 80s, using the Nobel Prize winning monoclonal antibody technology, we identified a series of islet cell antigens with the dream of making a vaccine. These are some of the antigens we characterized. We purified 2 glycoproteins. 87, Providence brought me back to India, and the last 27 years, I'm playing with the beta cells, but this time in flesh and blood. Thank you, that's the little story. This is my team from Bengaluru.